evening, everybody. Thank you, Laura. Didn't we say that? I got deja vu here. So anyway, for those that don't know, my name is Stuart Schlossman, president and founder of MS Views and News, an organization that we founded back in 2008. Why? Because we needed to be able to provide education for all those that didn't feel that the educational programs brought to them. Why also? Because they may attend a pharmaceutical program, and the pharmaceutical program is just speaking about that one pharmaceutical medication. Okay, and that's great for them, but those that attend our programs get to hear an A to Z about like all the different medications, and they get to hear about what's going to be happening, and they could hear about switching and knowing when to switch, or they could hear about MS relapse and learn more about this as well. And again, we're just providing an A to Z, an A to Z of everything that you might want to know about MS. As well as we always have at least a second speaker at our programs. And that could be a neuropsychologist or a psychologist or a urologist or a physical therapist or somebody that just gives a little bit more dimension to the program and allows you to learn that much more. Before I go forward, since we're speaking about the pharmaceuticals, I have to give thanks to Pfizer and Biogen IDEC for giving us the grants to do tonight's program. And I hope that you all appreciate it as well. Thank you. In addition to those two, our other sponsors are Accorda Therapeutics, Genzyme, a Sanofi company, Biogen IDEC, Questcor, Bayer, Novartis, and we also have to thank Holiday Inn tonight because they did give us something that we're using for our raffles. So I want to thank all of them for helping us out and doing this program. Being brief, I want to let you know that our speakers tonight, I'm sure you all already know, Brian Steingo, neurologist from Broward County, Florida, and he made the trek across the Everglades to get here today. Okay, and we're glad that he did, and hopefully you'll pick up a few new pointers from that maybe you don't get from others that you've gone to programs to listen with. In addition to Dr. Steingo, we have Mary Robinson, who's here to teach you all how to smile. Jeez. And she's going to teach you how to be in the now. I don't know what that is. I can't wait to hear this also. Please, everybody, we're going to do a Q&A following each presenter. So after Dr. Steingo speaks, we're going to do like a 30-35 minute Q&A. During that process, we're going to have microphones going out to the audience. These cameras are not here to pick up anybody out there. They're going to hear your voice, but they're not going to see you. So your identity is protected, okay? If you have a relative listening, yeah, they're going to know your voice. And that's probably what you want them to hear anyway. All right, but the cameras are not here for any of you. They are just here to pick up those that are in the front of this room that are going to be speaking. And after Mary speaks, again, she wants you all to know she needs to be able to go through the program because she might forget. All right, so she wants to go through all of her slides and speak with you, and then she'll do Q&A with you. And again, please wait till either I or somebody else gets to you with a microphone, so that way whatever you say can be heard on the recording too. Now, before we begin with Dr. Steingo, we always ask support group leaders in the area if they have something to say, keep it brief. We give them 90 seconds to say something. And so tonight, there are a couple of support group leaders here, but only one wants to come all the way up. So we're going to ask Karen Hart to come up here and say something, briefly. I know that's hard for Karen. You have to come over here. There you go. All right, once you step inside this box, you're good. Now you just got to turn and face that way.
Hi. I can't stand microphones. My name's Karen Hart. Most of you know I'm the facilitator with Dave Lane, who's sitting over there, for the Fort Myers MS group. We meet on Thursday evenings at 5 p.m. at St. Hilary's Church. And Dave is the Cape Coral facilitates the Cape Coral group, and that meets on Sunday afternoons from 3 to 4:30. Am I right, Dave? And at Cape Coral Hospital. And that's all I have to say, Stuart.
Well, thank you, Karen.
Was that fast?
That's great. And by the way, I thanked the sponsors and those that gave us the grants to do tonight's program. I did not get to thank our volunteers. I want to thank them. And, of course, I want to thank all of you for coming out to another MS Views and News program. By the way, between January and June, we have 18 programs lined up around the state of Florida, Birmingham, Alabama for our first time, Charlotte, North Carolina for our first time, and Atlanta, Georgia for our second time. These will all be happening between now and June. So, now we give you to Dr. Steingo. Thank you.
Thank you, Stuart. Thank you all for coming. Stuart gives the support group leaders 90 seconds, but you notice he doesn't limit his own time. Actually, tonight it was a short version. So this is a presentation that we've done on the East Coast and a little bit up the coast several times. So unless some of you have traveled, you wouldn't have seen this before. As you'll see, it's a big topic. There's a lot of different things that we might or might not cover. And sometimes when we do it again, for example, I'm doing it again soon at Signature Grand, and we've done it before, we're picking different topics. So we call this the land of MS. It's because you're entering the land of MS. When you're diagnosed with MS, you enter the land of MS. And it's not just a straightforward subject. It's very complex. There's many things we could talk about. And so when you come to the first one, I try to cover some of these. Later on down the road, we might emphasize something different. I might, for example, spend most of the time talking about the symptoms of MS. We could have a whole evening just talking about the symptoms of MS. We could talk about the diagnosis of MS, or how you treat MS, or the disease-modifying drugs. We could spend time on medical support, social support, self-help. Each one of these is a topic that could take hours on its own. So I'm just going to try and highlight some things for you. And usually when I do this to a group for the first time, I usually just go into it and start talking about it. And at some point, Stuart starts waving at me and says, stop. And that's kind of when I'm going to stop. And then we can do any questions at that point. Down is up and up is down. Can somebody remind me that? Maybe you can do this for me up and... Oh, that was up, so that's down. Maybe I can just walk up to the laptop and hit the button. Okay. Oh, okay. So the first thing I want to talk to you about is, what is MS? Now, when you go to pharmaceutical company lectures, you know that every time that you look at the lecture, there's something about what MS is. It's a demyelinating disease. But I've got this little, which I created myself, about what MS is. And that is to tell you that MS, we all think of MS as a demyelinating disease of the brain. But it's important to know that in MS, the brain, the central nervous system, the brain and the spinal cord is the target. It's not the cause of the disease. It's not the primary cause of MS. What sets MS off is something happens in the immune system. That's the cause of MS, something happening in the immune system. And when the immune system goes wrong, it attacks different organs in your body. If it attacks the brain and the spinal cord, you get MS. If it attacks your joints, you might get rheumatoid arthritis. If it attacks your thyroid gland, you might get Graves' disease or some type of thyroid disease. So whichever organ is the target is the disease you're going to get. But we're talking tonight about where the immune system goes wrong and you get involvement of the central nervous system, the brain and the spinal cord, and something triggers it off. We don't know what the trigger is. What causes someone to have MS? There are various factors involved. We can look at some of those in a minute. Genetic factors. So yes, if you have MS, then other people in your family, your children, your parents, your siblings, all of them have a higher risk of getting an MS. They do not inherit the disease directly. What they inherit is susceptibility. They will be more susceptible to getting MS. And so what makes them, if they're susceptible, why don't all our kids get MS? Because there are other factors that in a susceptible individual trigger it off. And they're mentioned over here, environmental factors. We know people that are living up in the Midwest or northern latitudes have a higher incidence of MS. So there are some environmental factors that are probably involved. How about infections? Yes, we know Epstein-Barr virus. Mono is an infection that seems to trigger MS in a susceptible person. And a very important factor, environmental factor, is vitamin D. So if you have someone who is susceptible to MS, there's a family history of MS, and then they are vitamin D deficient, and they live in the wrong place, and other factors such as smoking, for example, all these things, you put them together, and you're setting up the risk of MS. So you have to watch this for a second. So now something triggers off the MS, and activates the immune system. The lymphocyte is a blood cell in the immune system, and now this cell has to get from the immune system to your brain. So you have to watch what happens carefully now. T cells and B cells are activated. Did everyone see the arrow flying across there? I hope so. That's about probably as quickly as it happens in your body. So a cell got activated, and it has to cross, in order for it to attack the brain and the spinal cord, it has to cross this structure called the blood-brain barrier. That's important because some of the drugs that we have, in fact, probably the most potent drug we currently have on the market, works at that level, at the blood-brain barrier. Many of the drugs we have for MS work over here on the lymphocytes, but some work at the blood-brain barrier. So that is what happens in MS. So these lymphocytes are inflammatory cells. Oh, there's another arrow, and that's just showing you how one medication blocked the blood-brain barrier. That is Tysabri, which blocks the blood-brain barrier and prevents the lymphocyte from crossing and attacking the brain and the nervous system. That's how that particular medication works. Okay, so we talked about this already. The triggers stimulating the lymphocytes causing inflammation, the inflammation attacking your myelin, the myelin becoming demyelinating disease. Eventually you can have an actual loss of the nerve cell, that's called the axon. If myelin is damaged, there can be some recovery. If this structure, the axon, is damaged, there is no recovery. So we want to stop the process and treat it as early as possible to prevent the damage to the axon, which can eventually lead to atrophy, which is permanent. This shows you over here, I'll put this up over here, is just to show you inflammation. So if you look at the corners of this slide, both the right and the left corner, that is normal brain tissue, normal looking brain tissue. But in MS, we said there's inflammation. And we said these cells went through the blood-brain barrier. So here's a blood vessel, and this over here is a massive amount of inflammatory cells that cross the blood-brain barrier, and now you see this massive inflammation around the blood vessel, and that's how you see how different this is from normal brain tissue. That's what MS looks like. If we could take a piece of tissue, we would see this huge amount of inflammation commonly originating around the blood vessel. Now, what about types of MS? Most of you know there's a couple of types of MS. You know that there's relapsing remitting MS, which is the commonest type of MS. 80 or 90% of people start out with relapsing remitting MS. And then there are some people that have progressive MS right from the beginning. That's called primary progressive MS. Some people that have relapsing remitting MS after many years may develop progressive MS. That's called secondary progressive. So relapsing remitting MS without treatment can go on to secondary progressive MS, and sometimes even with treatment if it's not working effectively. There were studies that were done even 20 years ago that showed if you had relapsing remitting MS and you weren't treated, about 15 years after the diagnosis, up to 50% of people were starting to progress already. 50%. So if you think about a person with MS is often young, 20 to 40 years old at onset, and now 15 years later, 50% of people are starting to progress. It's a significant number still at a young age. And 25 years after the diagnosis, without treatment, 80% of people are developing secondary progressive MS. So that is why, another reason I'm telling you now why we like to recommend treatment early on. You'll see two other things over here. Clinically isolated syndrome. This is a new concept that we've had in the last 10 or 15 years. That refers to your very first episode. So in the past, for some of you who've had MS for a long time, you'll know when you have your first episode, we're saying, this is suspicious for MS, but we can't diagnose it till you have your second episode. Well, now we have criteria and MRI scans that allow us to diagnose MS after the first episode. And the very first episode that you might have, for example, optic neuritis or whatever it is, we might call that a clinically isolated syndrome. It's an isolated event. It's the only one you've had. But based on your scan findings, we're able to say this is MS. And so this is the very earliest sign of MS when we can already start treatment. And now we have an even earlier stage than that. It's the radiologically isolated syndrome, RIS. And that is when you have a scan for some other reason, because you slipped on the ice and bumped your head, or somebody hit you on the head, or you have headaches or anything. Any other reason you have a scan, and guess what? It looks like MS. It shows signs of MS, but you've had no symptoms of MS at all. It is an isolated radiological X-ray finding, and you don't have any other symptoms of MS. And now they've studied these people, because there's enough of them over the years that they've accumulated, and found that a significant number of them do go on to develop definite MS to have other symptoms. especially if the MRI of their spinal cord is abnormal as well. So if I see someone like this, if someone like that is referred to me, I send them for an MRI of their spinal cord, and if that is also abnormal, I'm going to say there is a higher risk for developing definite MS, and we're going to be more vigilant. We don't treat this yet. We don't have enough knowledge to treat people with RIS, but we watch them very carefully. So these are stages of MS. These are the early stages before relapsing remitting MS, and these are the late stages after relapsing remitting MS. I just wanted to point out all these different stages. This bottom one over here, progressive relapsing, is rare. It's somebody who has progressive MS and all of a sudden out of the blue has a relapse. It's a rare type. Now, what happens when you have a relapse? And it's always a question. Some people say you don't have to treat relapses. There have been people who have said that. And what this basically is showing you is they're looking at people after a relapse. And this is 90 days. Let's look at this one on the right only. Let's pay attention to that. What happens 90 days after a relapse? And this is looking at a disability scale. So we use a disability scale that some of you might know. It's called an EDSS disability scale. Any of you have been maybe in a clinical trial. Most neurologists don't use it in day-to-day practice. It's kind of cumbersome. But if you look at people that have had a relapse and you look at them 90 days later, you'll see that altogether about 41% of people, even 3 months later, still have at least a half-point decline in their disability. So 40% of people. And 30% of them, 1/3 of them, have a point decline in their disability. Let me give you an example of what a point is on that scale. If you have a disability of 5 on that scale, the EDSS scale, a 5 is you're walking independently. You might not be walking normally, but you're independent. You don't need any assistive device. 1 point drop to 6 is using a cane. 1 extra half point, 6.5, is using a walker. So especially when you already have some difficulties, something added onto that really is a more severe compounding effect. So it is important, we believe, to treat relapses. Now, when you come in for the first time and you have MS, or you've had it for a while, you're saying, is there any way we can predict how you're going to do? Are there any factors we can use to help us predict what the outcome is going to be? And here is something that was done by Dr. Scott in Pittsburgh, and he looked at 6 things that we could look at and say, we could add these together and say what your risk is. So the first one was age at onset. And what that is that the older someone was at the onset, then the likely outcome would be a little worse. And then the symptoms at onset were important too. So let's talk about a good symptom. What's a good symptom? Optic neuritis. Good. If you're going to pick a symptom, you don't want to pick any symptom, but if you pick one, pick optic neuritis for your first symptom, as opposed to your first symptom that you have is that you come in and you have trouble walking and your bladder, lose bladder control. That is exactly the opposite. That would be a very worrisome early symptom. So your age at onset, your symptoms at onset are very important, and then how your MRI scan looks. How bad is the MRI scan? How many spots does it have on it? And then the time between the first and the second attack. And then the number of attacks you have early on, and then how much do you recover from your episodes. So we put these 6 things together, and we look at them, and within a year or 2, we can say how you're going to do. The more that you have of them, on the right-hand side, the more you have, the greater the disability. That's what this basically shows. So this will help us decide on treatment. If you have a very benign-looking kind of pattern, you might say, I want to wait and see. I'll do other things. I'll wait. But if you have a bunch of these, I think we would stress, I would show you this exact table, and I'd say, don't take risks. We know what your risks are. So that helps us predict. Now, what about the MRI scan? How does the MRI scan help us? So it helps us in the following way. The first thing I'm going to look at over here is when you have come in for your first visit and you have an MS symptom, and let's say it's optic neuritis, and we look at your brain scan, and you have no spots on your brain scan, 0. So you have a brain scan, you have optic neuritis, you've got no spots on your brain scan. What's your risk of MS over the next 10 years? About 20%. If you have 1 spot, what's your risk of MS over the next 10 years? 80%. If you have 10 spots, what's your risk over the next year? 80%. So it doesn't matter. Once your scan is abnormal, you have an 80% risk of developing definite MS, meaning other symptoms. So what about the number of spots? Does that make a difference? Yes? So let's look at this one on the right-hand side over here. Once you've got a spot, you have a risk, but the number of spots gives you a greater risk. So look at the right-hand side. If you have 1 to 3 spots, this is a disability scale. And so if you look up over here at greater levels of disability, it's measuring greater disability. The more spots you have, the greater the disability. So when you come in and you have optic neuritis, even a mild symptom, and you have 10 spots, I know that your disability is going to be much greater at 10 years than somebody that has one spot. You both have a risk of getting MS, but your disability is likely to be greater. So it's again telling me, let's be aggressive about the treatment. Let's not sit around and wait and see and come back in 6 months. Let's be more aggressive. So those are some of the facts about us wanting to treat early, and it's saying the same thing. I'll leave that one. We talked about this a little bit, is what happens if you don't take treatment. So this goes back about 20 years. In 1990, the Mayo Clinic did a study. I've talked about this already, but I'll just summarize it for you. And they said that if you look at all people with MS, most people start out with relapsing or remitting MS. There are some people that start out from the very beginning and have what we call malignant MS. It's just rapidly progressive. They go downhill quickly. They're disabled quickly. They don't respond to drugs. It's just a very, very bad type of MS. Only about 5% of people have that type. But as I said before, if people were untreated in 1980, at 15 years after the diagnosis, 50% of people have progressed. They're now secondary progressive, 50%. So you had someone who started out with MS when they were 20 to 40, now they're 35 to 50, and they've progressed at 15 years. And at 25 years, 80% have progressed. So more ammunition for us to say, let's do whatever we can to change the course of the disease. And this is where I believe the drug. We have no drug that is a cure. You all know that. But the purpose of the medications is to prevent this from happening. Stop this progression, slow this progression, change the curve. That's what we're trying to do. This is the most exciting slide of all. It's complicated. Well, if you looked at it for a minute, you'd see it really wasn't complicated. What this slide is the slide of what happened to MS since 1993. If we were sitting here today 20 years ago, or 21 years ago, at this time in 1993, and we said, what are the drugs that are approved by the FDA for treatment of MS? How many drugs would be on this slide? 0 is the answer. It's correct. Now we have 10 approved medications up to here, 10 approved medications, including 3 oral medications, 10 approved medications now. Number 11 should have been approved by the FDA. It's a drug called Lamtrada. The FDA, in their wisdom or lack of it, decided not to approve it at this point, although it's approved in Canada and Europe and Australia and Mexico. Yeah, even Mexico approved it, but we couldn't. And so this is a very effective drug. Yes, it has a lot of side effects, but it's used for specific people. I told you there were 5% of people that have malignant MS, but there's 25% of people that have severe MS. And this option is not approved. There's a lot of appeals going on. On the right-hand side over here, these 3 names that are hard to pronounce: ofatumumab. How would you like to get ofatumumab or ocrelizumab? These medications on the right-hand side are all in clinical trials, which hopefully we're going to have in the next 2 or 3 years as well. So I told you now we have 10 drugs. In the next 5 years, we might have 15 drugs available for MS. So there's a lot of stuff going on. Exciting slide. And there's experimental drugs. There's some experimental drugs that are going on, including a T-cell vaccine, a vaccine against MS. And then there's studies about using other common drugs. What do they do for MS, such as statins and vitamin D? What's the importance of vitamin D in MS? Very important. And then some new experimental drugs over here as well. So a lot of stuff is going on, a lot of research, a lot of things happening. And so the goal of our treatment is very clear. We want to stop you from having relapses. We want to slow the progression of the disease. We want to reduce the MRI changes, so your MRI doesn't progress and develop atrophy. We want to reduce your symptoms. We need to make sure you take your medication. We need to make sure drugs are as safe and as effective as possible. These are some of the goals we're looking at whenever we look at new drugs that are in trials. How do we make a treatment decision? Do you think this is a complicated slide? Who thinks it's not complicated? It's very complicated. And this, every time you see your neurologist, unless you're completely stable, when we're thinking of situations that you have, this is the slide we have to go through. So at the beginning, what medication are we going to start? What is the starting medication? We have to think of all these things. Now let's say the medication may not be working. We have to switch the medication. Again, we have to go through all these things over here. Is the medication safe? Does it work? So does it have safety? Does it work? Does it have efficacy? Is it tolerable? Is it going to cause side effects that are intolerable? Those are some of the things we have to think about. But there's other things. It could be personal preferences. It could be a stage in life, such as pregnancy. It could be the cost of the drug. It could be what the insurance company allows. So there are many things that we're going to look at over here. How convenient is it to take it? What's the monitoring involved? All these things we have to think about when we start a new medication, and when we switch from one medication to another. These are all important things that we have to think about. It's important to have realistic expectations as well. We said before, we don't have a cure for MS. So what's the purpose of these medications? It's to stop the relapses and slow the progression. And in fact, in some people, it's almost a cure. They may have no further activity. But in some people, it might not do very much. So our expectation should be realistic. These drugs are drugs that are used to stop the progression of MS. They do not make you better. They do not deal, we've said before, that in MS there's inflammation and there could be demyelination and scarring. And these drugs don't reverse those findings. So they don't take away what happened before. They're to prevent future activities. It's very important. I see people frequently, or sometimes, who might come to me 6 months after starting a medication, and they might say, this medication X is not working. And I'll say, how do you feel? Great. Have you had any relapses? No. Well, how do you say it's not working? I don't feel better. Okay. Now I have to work on your symptoms. We talked about the land of MS and the symptom tower. So that's where we get now into the symptom tower. So we say, we're moving you to another building. You're going over to the symptom tower. We're going to work on your fatigue, and we're going to work on your bladder, and we're going to work on your depression and your pain and your burning and your symptoms. We're going to work on your symptoms in a different building. We're not going to work in this building. This is the building to try and stop this disease from progressing. So the expectations are important. If you're not better, is there something else we need to be dealing with? And it's not your disease. Your disease is stable. It's the symptoms that we might have to be dealing with. And this was one study that was done. There's been several studies that have shown that if you put people on medications, do they stay on their medications? This was done in Ontario, where it is a captive population, as we soon will be, where, in other words, they know exactly what you're taking, when you're taking it, what time of the day you're taking it, what you had for breakfast, everything about you. And so here they said, how many people over here are taking their medications? And look at this, after 2 years, how many are still on their drug? 50% of people are taking their medication as prescribed. And I bet it's no different over here. I see it all the time. 50% of people are taking it as prescribed, and some not even taking it. That can happen. I saw somebody last week that I hadn't seen for a couple of years, and she came in with her husband, and she was having a clear relapse, and I said, well, this medication is not working for you, and she said, I'm not taking it. She admitted it in front of her husband, and she is an ICU nurse. I was quite surprised. I said, you know, you're medical, you should understand the importance of compliance. They've done other studies. Recently, they published a study where they said that the compliance rate with the injectables was about 75%. In this other study. And does anybody want to guess what the compliance rate was with the oral medications? So that was the thing people said, now the new oral medications are coming, we're going to take pills, we don't have to take injections anymore, give us the pills, we'll take them. So who wants to guess what the compliance rate was with the pills? 75% with the injection? Yes, lower, 71%. Lower than with the injectables. It's because people forget their pill. How often can you forget a pill? Yeah, you forget the pill. Especially if it's twice a day, you forget it. Or you feel good. No, I don't have to take it today, I feel good. So compliance rate reduced. And if you don't take them as prescribed, they're not as effective. And this is some of the reasons why they're saying why people don't take their medications is because they don't like needles. They have expectations that are not appropriate. We just talked about that. One of the other things is that depression. With MS, there is an increased risk of depression, and people who are depressed don't take their medication as prescribed. And this is just the same thing about talking about how we get you to adhere better, to explain to you. So everything I've been through already are the things that we would want to talk to you about, that your neurologist should talk to you about, or that you should be talking to in a support group about saying, I understand now why I have to take my medication. And if I have a reaction to the medication, I need to talk to my neurologist about it. And if I think it's not working, I need to talk to my neurologist about it. And if I have symptoms, they may be unrelated to the medication, or they might be from the medication. So these are all things you need to write down. To make your office visit worthwhile, when you go there for the visit, you should have a list of your symptoms. In my office, every time patients come in, they write a list of their symptoms. And it summarizes from the vision to the walking, to the numbness, to the weakness, to the bladder, to the bowel. Every single question is listed there. And at the end of the visit, when they go home, we give it to them. We say, take this home and bring it next time you come. So I have a list of your symptoms. Very important. Makes the visit much more worthwhile when you come in and give the neurologist so he can look at it in 1 second and say, now these are the symptoms we have to be thinking about. You might write none. That's the one I like best. None. There's nothing. I have no symptoms. I'm care for a routine follow-up. I feel great. I like that. It's much easier, but it doesn't happen often. Okay, so you list your symptoms. What else do you write on the piece of paper that you take in to make your visit worthwhile? Second thing I want everybody to write is their medications. And I want to write every supplement. I want to know if you're taking vitamin D or CoQ10 or whatever else you take. I want to know what supplements you're taking. And people often write the same. The lazy way out. Same. Unchanged. So if I could get $1 for every time somebody writes that and they're wrong, I wouldn't have to be working tonight. I would be somewhere else. And the third thing I have them write on the piece of paper is their questions. This is a standard thing on our printout is questions. So you come in and you give me your sheet and it says, today these are my symptoms and which are changed and not. These are my medications and these are my questions. I'm having more bladder frequency. I'm having more burning. I'm tired. I feel great, whatever. These are my questions. Can we discuss a new oral medication, whatever it is? The minute I see that, within 25 seconds, I'm thinking, okay, now I know where our discussion is going to go and it's going to be valuable. It's not going to be rushed and suddenly I remember another. It's going to be a valuable discussion. And this is talking about when you start treatment now, some of the things we need to talk about. Again, we've spoken about some of them. But going forward, what we're trying to do is personalized treatment. That is, ideally, if we could take you and put you into a little computer and everything you want about a medication and your insurance company wants and you're comfortable with and your other medications are, and come out with what's right for you. We can't do that quite yet. But these are some things that you might look at. How do you, what blood tests do you need for this? Do I need to see a cardiologist? Do I need to see an ophthalmologist? Do I need to have an EKG? Do I need to have blood tests? Do I need a TB test? What do I need to have done? What's the cost and the convenience? What's the risk of this drug? What's the benefit? Let's weigh them up, the risk and the benefit. How are they? And then these key things at the bottom over here are always the key things you ask for every drug. Does it work? And if it didn't work, we shouldn't be talking about it. Does it have efficacy? Is it safe? What's the safety of this drug? Now I have to look at the risk and the benefit. I know this drug is an effective drug, but what's the risk? How do we monitor for that risk? And is it tolerable? Am I going to have flu-like symptoms? Am I going to have a lot of injection site reactions? Am I going to have diarrhea or indigestion? And what are the symptoms? These are all things that we look at. This is some other things we have to look at. So just in case you think it's all easy, I mean, these are all things we have to be thinking about. What other conditions do you have? For example, could you have a heart condition or an eye condition that might limit our medication? How bad is the disease? How aggressive do we have to be at the treatment? Is there a family history of diseases? We talked about childbearing potential. JC virus currently applies essentially only to Tysabri, but going forward with our newer drugs that are all potent, this might be something very important. How is your immune system? These are all things, again, that we're thinking about. I put them up. Some of these slides are going over things, but I just want to emphasize some of these points. More things. You think it stopped there? These are all things, all conditions that we need to know about. Let's just pick on some of these. Hepatic dysfunction. Hepatic dysfunction means liver dysfunction. We have 10 drugs approved for MS in 6 different classes because of the 10, 4 of them are interferons. 6 different classes. They all work differently. Copaxone works differently from interferons, works differently from Gilenya, works differently from Tysabri, differently from Tecfidera, different from Abaja. They're all different mechanisms. Of these drugs, if you read up their side effects, can they affect the liver? And the answer, of course, is yes. Every single one of them says to you, warning, this drug could affect your liver, except for one. Right? You know which one that is? Somebody knows. Copaxone. Copaxone is the only one that doesn't seem to affect the liver. Every other one does. We have to think about that. If you have liver disease, I saw somebody today that has a condition called primary biliary cirrhosis. It's an autoimmune disease of the liver, which can be a bad disease. And I'm saying, what can we give you? I don't know. She was sent to me by another neurologist for a second opinion. I said, I don't know what to put you on. There's only one drug that doesn't affect your liver. Diabetes, cardiovascular disorders, we have to think about. These are chronic diseases. We have to think about how do they all interact with each other. And we're talking about now, we've started you on the medication. We've been through everything we've talked about. We've looked at safety, efficacy, tolerability, cost, all those things. And now starting or switching. When do we decide to switch you? And what are the things we use to switch? So the first thing we're looking at in terms of switching you is your drug is not working. And how do we know it's not working? And there are 3 ways we can think about that. The first way is what I say is you. So you will come to me and say, I am having a relapse, I am not doing well, and I have to think, is your drug working for you? The second way is the examination. Is your disability worse? What do I find? And the third way is the MRI scan. So there are three things we can look at to measure how you're progressing and say, okay, this medication is failing for you, you are breaking through, we need to make a switch. And when we switch and look at the new drug, we have to look at these same things all over again. The safety, the tolerability, the cost, the convenience, all those kind of things. Now, one of the things we have to think about over here at the bottom, if you look at that, is sequencing. How do we follow your drugs? Which one do we pick after another one? Because some drugs are more powerful suppressors of the immune system than others. And if the drug suppresses the immune system in a powerful way, it might take longer for your immune system to recover and might limit or change our use of other drugs. So going forward, things we're thinking about are starting, switching, sequencing. What do we use next? So no, we don't want to use this next, because if we use this and it doesn't work, it's going to take a long time before we can give another medication. So usually important things we have to think about. And then lifestyle things, we've talked about things especially such as pregnancy, important lifestyle consideration, or it might be your support. What kind of medication do I have? What kind of side effects are there? I might need a little more support for this. Finances, cost, convenience, the same things again, and it's all said in a different way. And then how do you monitor the medication? Now I've decided on the medication. I like this medication. It's got good safety features. It works well. I can see I can tolerate it. But now how often do I have to monitor for it? Do I have to do regular blood counts? Do I have to check my liver? Do I have to do EKGs? Or do I have to see an ophthalmologist? What kind of testing do I need to do? All these are things we're going to be thinking about. And this is just the same thing about the safety of the drug, different drugs having different safety issues. This I'm not going to go into for this particular presentation, but I only put this up over here because we said previously that we could easily move you over to the symptom tower because there are widespread symptoms of MS. So each one of these we could spend, and I'm sure you've had those kind of presentations, someone talking about the bowel and the bladder. Or we could have a neuropsychologist come and talk to you about cognitive dysfunction, a very important symptom of MS and a very disabling symptom. In fact, more people actually lose time from work and stop working because of that than their physical problems. And then managing all these things over here, weakness, spasticity, loss of balance. So there are lots of opportunities for us over here. And I think Stuart is going to give you, Stuart, right? You're going to give him something to fill in?
Seminar evaluation.
Yes, yeah? You have?
They already have it.
Okay, so he's going to give you an evaluation form. It's very important that you fill in on that, things you want Stuart or others to do for you in the future. You might say, I want symptom management. Let's do more cognitive stuff. Let's do more bladder stuff, whatever you feel is an unmet need. It's an important slide. Don't look at it. It's detailed, it's complex. And I hate complex, detailed slides when people put them up at a talk that I go to. But it makes a point. And what it says is the following. These are some of the drugs to treat some of the MS symptoms. We might give you something for fatigue or depression and spasticity and pain and constipation and your bowel and your bladder and your tremor and your walking. And guess what? At the end of the day, you could be on a whole bunch of medications. And then you have other conditions. You might be diabetic or have heart disease. And how many medications are you taking at the end of the day? And what do you think the potential is for interaction? Got to be aware of that. Okay, it's very important. Every time you start a new drug, let's say, does it interact with what I'm taking already? Let's see how this fits into my profile. I'm a person. Don't just give me this drug for my MS. Let's see how it reacts with everything else. And there are simple tools that your neurologist could use. The pharmacist probably will use them when the drug is prescribed. And the tool I use is very simple. It's on the phone. It's just a drug. It's an interaction checker. And all I do is type in your medications and the new medication, and it tells me it says interactions. And again, more often than not, I find that there's an interaction between two drugs prescribed by someone's primary care physician than what I'm giving them. So it's interesting to look at that. But remember with your medications, we need to look at that when we add a new drug. Don't forget all the other medications. That goes back to what I said 10, 15 minutes ago. Give us a list of your medications. Keep it updated. Show me what you're on. So when I add something new, I know what's going on. There's some of the new medications for walking, for example. There's a drug called Ampera, which is used for walking. And it's effective in about half the people that take it. But it has one potentially serious side effect, which fortunately is rare, and that's seizures. It can cause seizures. Now, I need to know what else you're on. Or you're on other drugs that could cause seizures. We don't want to look for trouble. That's polypharmacy, taking many different drugs. We don't have to do that. That's the end of that section. Stuart, how are we doing there?
You have another 10 minutes.
10 minutes, okay, good. This itself is a hugely important section. I'm doing one of these in a few days, and we're only going to talk about this section that I'm doing now for you, because we've done the other section with them a couple of times already, so we're going to do only this section with them. And this is the section of self-help. And I have the acronym for self-help. The one before was the old one. This is the new one. And it's easy to remember. It's a team of friends and things to think about that you do for yourself. So T is temperature. You know, people with MS are heat sensitive. How do I manage my temperature? Stay out of the heat, get a cooling vest. If I want to go outside, I want to do a little bit of exercise, keep it cool, wear a cooling vest. E, and you can make up any things you want on here. This is just what I came up with one day. E was expectations, and we've spoken about them. Have reasonable expectations. The more reasonable they are, then the more easy it is to manage the condition. A was adherence. Obviously, take your medication, and we talked about compliance before. If you don't take the medication, can't help you. Mental, all the mental aspects, and that includes dealing with stress, memory problems, all the cognitive issues. Dealing with all of those, a huge topic that we could talk about. The one I added to this in the latest version of this, I called it teams of friends, and the S that would fit in over here somewhere, there'd be an S, was sleep. Managing sleep, it's difficult. People with MS often don't sleep well, and these things interact with each other. If you don't sleep well, then what do you have more of? Fatigue. So sleep is very important. Yes, S could stand for many things. I've got the one over here of smoking. I was thinking of making it stress, but then I said I've got mental covers stress. So sleep. And they have shown that sleep disorders are common. Recently, a paper was just published in the last month that said that sleep disorders are very common in MS. So I have sent some patients for sleep studies, and I'm going to be inclined now to send more people for sleep studies. They actually showed that a good percentage of people have obstructive sleep apnea. And the other reason why it's good for us to send people for a sleep study is because if you have fatigue and you need Provigil or Nuvigil, 9 out of 10 times we're fighting an insurance company to get it for you, and we can't get it. They just fight, and we struggle to get it. But if we do a sleep study and it shows some kind of sleep problem, we might be able to get it. So sleep becomes very important. And sleep is complex in MS. Why can't you sleep? You might be going to the bathroom 5 times at night. You have to get up. It's your bladder problem. So it could be that. What else? It could be pain. It could be spasticity. It could be many reasons why you don't sleep. So when you say you're not sleeping, we have to analyze why are you not sleeping? Which of those factors is affecting your sleep? And when you have fatigue, we have to say, why are you fatigued? Is it just because you have MS? Yes, that could happen. And we call primary fatigue of MS. You're just fatigued because you have MS. Or could there be something else causing your fatigue? For example, you don't sleep well at night. You're not sleeping well at night, and so you're fatigued the next day. Or are you taking a medication that's making you fatigued? Were you just given an antidepressant or some other medication that could make you tired as well? And then food. A whole discussion. We could talk all night about nutrition, which is kind of controversial because some people feel it's very important, some people feel it's not that important. I think it's very important. And then relationships, which interacts with support groups, like what you're doing here tonight, this kind of support group, a support group of the MS Society or the MS Foundation. All these kind of things, interactions and relationships, all very important. The better the support that someone has, there's no doubt that they will do better. And then exercise is hugely important. And keeping up with the news, keeping up with information is important too. And then D. I put D as a separate topic from food or nutrition. You could play around with this. Sometimes I've had N as nutrition. But D is so important. Vitamin D is so important for MS that I gave it a separate heading, separate from nutrition. And then smoking. And so I spoke to you right at the beginning. If we go right back to when we started, I said to you, who gets MS? And we said that you have a genetically susceptible person, and it might be a family history, it might not be, but you're genetically susceptible, and then other things trigger off your MS. And one of those could be infections. And the one infection we know about, mono. There might be other infections. They're writing about some other infections now. They're studying some other infections. There are studies ongoing about other infections. There are infections now where they're studying the bacteria in the gut. And they're saying that if the bacteria in your gut are abnormal, then you might have an increased risk for MS. And particularly they're talking about, I don't mean to put anybody off their diet, but red meat. So there is some evidence now that red meat might affect the bacteria in your gut and might increase your risk for autoimmune diseases. Red meat is what they're talking about. But with vitamin D, they published a study recently in which they correlated the vitamin D level with the progression of the MS. So what they showed is that higher levels of vitamin D were associated with slower progression of MS. And this also goes back to compliance, because what I do now, every single person I see, either I get the vitamin D from their family doctor or I do a vitamin D level, and I say you need to take vitamin D. Whatever type of MS you have, you need to take vitamin D, and we need a high level. The normal range in most laboratories is 30 to 100. If you have MS, we like it to be running about 75. We want a high level of vitamin D. And can it be toxic? It's rare. Vitamin D is a fat-soluble vitamin, so it can be toxic if you take too much, but we can measure the level, and we can see if you're becoming toxic, and it's rare. I think I've seen it once. So it's very rare. So we want your level to be up. Monitor the vitamin D level. And the other vitamin that is important is B12, because it's an important vitamin for the nervous system. So D12 and D and B12 are very important. And smoking is another risk factor that correlates with MS progression. So things you can do, for example, are you can take your vitamin D, you can stop smoking, you can exercise. These are all very good things you can do. If you have family members and you're saying, I have MS, you have some risk, you might inherit genetic susceptibility. What should you do to slow down your risk? Don't smoke. Take vitamin D. So these are all the aspects. Okay, I can wrap it up there. Okay, so well, I think I'll wrap it up over there so we can so you can listen to someone else. And
Q&A.
Q&A?
Q&A.
Oh, you don't want to do it at the end?
For you.
Oh, okay.
No, we're going to do them separately.
Oh, okay. All right. Okay.
Okay, so as I was saying earlier,
I'll put the water.
first off, thank you, Dr. Steingo.
You're welcome.
So this is where I need your help. I need to lose weight. I have to bring you the mic. I hope there's a lot of questions so I can get around the room, okay? So who's first? Who's got a question? There we go.
Very good presentation, Doctor. I'm a neophyte with now my knowledge of MS, but I'd like to ask you, is there anything that with the human genome, like they're now saying that they can have markers and genes for women for breast cancer, is there anything like that that's being done for MS?
Yes, there is. So the question is about, oh, you heard it from Stuart there. So the question is about gene work in MS. Very good gene work going on, two places. In California, Dr. Hauser, major gene work is going on. And at the University of Miami as well. At the University of Miami, they have an excellent program as well. I know in our area, if we call them, they'll actually come up to people and take their blood. I don't know if they'll travel this far, they might. Especially if someone has a family history of MS, and there's several family members, it'd be very interesting for them to get the blood samples. And so what they've seen with MS is that there's multiple genes that seem to be involved, and they're working on trying to determine a pattern. We don't exactly have a definite pattern. And the way this will help is, I did refer to it earlier, can we look at your pattern and predict from that what kind of MS you're going to have? What kind of drugs you might respond to? So going forward, yes, looking at the genome and the genetic pattern is going to be very important. But it's still being elucidated.
Hi, thank you, Dr. Steingo. Yes, thank you. Could you tell us a little about the new trial that's starting next month with the T cells, where they're taking like 500 cc's of your blood and taking out your T cells, and what are they, radiating them or something and putting them back in you?
Yeah, I can tell you brief stuff about it. So
Okay.
I don't know about every trial.
I guess my question is,
Yeah.
have they done a preliminary study?
Yes, they have, is the answer to that.
And how's that?
So in our office, we do clinical trials. That particular trial we're not doing. The place to look and to get information about all trials, and you may have looked there, is clinicaltrials.gov. So if anybody wants to look up clinical trials for MS, go on the internet and look up clinicaltrials.gov, and then there's a little place where you can type in whatever you're searching. You can search anything you want. You can put in primary progressive MS, relapsing MS, a T-cell vaccine, anything you want to put in, you put in there, and what that trial, what that site shows you is any trial with MS that's approved in this country, FDA approved, any trial that's FDA approved is going to come up. It's going to tell you about the trial, what it is, and it's going to tell you the sites where they're doing it. So I've heard that there is a site in Orlando. I'm not sure. That's what I heard for that particular trial. So that medication, the T-cell vaccine, is called, the one that is coming up is called T-Celna. T-C-E-L-N-A, T-Celna. It was tried in the past. In the past, it was called Tovaxin. And yes, what they do is exactly what you say. It's almost like making a vaccine. It's the same as a vaccine. What is a vaccine? A vaccine is you take a virus, the flu virus, and you kill the virus, and you inject it into the body, but the proteins are still there, so your body makes antibodies to the virus, and if it gets exposed to the virus again, it can attack them because it's got antibodies. So with MS, you're doing the same thing. You're taking lymphocytes that are bad lymphocytes that have been attacking your immune system, and you take them out the body, and you irradiate them, and then you inject them back in, and your body reacts to them. And now you've got, in a sense, your antibodies to attack T cells in your body. So, I mean, the initial study was done more than 5 years ago. It was somewhat effective. It wasn't a slam dunk. So it is going on. It is an interesting new approach. If you go to that site that I'm talking about, you'll see there are probably close to 100 different studies going on for MS.
Just so everybody knows, on the MS Views and News website, OPEXA now has a banner there that it's their medication, the T-Celna.
Right.
All right, and so you can just click on the banner and it'll open up to their site so you can read all about this trial medication.
Is there a site in Florida, Stuart? Do you know?
No, I don't.
Yeah, I heard.
You can go to the website and click on the banner.
Yeah. Naples? For T-Celna? Oh, okay. Good. Yeah, we did the preliminary study called Tovaxin. It's a difficult study. People have to come from the blood bank and take out a large amount of blood, and then they harvest the blood. It gets sent away. It gets treated. It comes back again. But we at this time are doing several other studies, and it was just too hard to. You can't accept every study. You have to limit kind of what you're doing. So, but it is an interesting, important study.
Dr. Steingo, I read recently that primary progressive is about degeneration and relapsing remitting is about inflammatory. So could you explain that a little bit?
So yes, so the question is, are they the same disease? Is it all the same disease? Is it stages of the same disease, or maybe it's different diseases? Let me give you an example. If you look at people with MS and you say, look at 10 different people who were diagnosed on the same day and look at them 10 years later, one of them is running a marathon and one of them is in a wheelchair. So we know that MS is what we call a very heterogeneous disease. It's very different in different people, and the question is, are there different kinds of MS? So this is the first question that comes up. And then we know from the very early stages, they've studied MS in people that have just been diagnosed and then had an accident. Something else happened to them. Not when they died from MS, but something else happened. They had an automobile accident, they died, and they looked at their brains. And when they've studied their brains early on, right from the beginning, they've already seen that right from early on, there is some degeneration. And degeneration means you're losing cells. So if you remember very, very early on, I showed you that slide, and it said that you started out with the inflammation and the demyelination, and you go into the loss of the axon, and eventually there's atrophy. And atrophy is degeneration. Degeneration means you're losing cells. So inflammation is when something is inflamed, and all those cells were around the blood vessel, millions of lymphocytes, white blood cells around the blood vessel, causing damage, and then the brain shrinks. That's degeneration. So it's a later process, but in the primary progressive MS, it seems that there's less inflammation and there's more degeneration early on. But there does seem to be some recent studies are suggesting now that even in primary progressive MS, that there is some inflammation, and that in relapsing remitting MS, there is some degeneration. So there's some overlap between them. But all these drugs that we have that I showed you, that exciting list of medications, are predominantly for inflammatory forms of MS. That's why they don't work so well or at all for primary progressive MS. And that's why we need to find some different drugs for primary progressive MS that are going to slow down the atrophy.
Would that mean if it's about inflammatory, that Solumedrol, maybe IV Solumedrol wouldn't work on somebody with primary progressive if it was just about degeneration?
Yeah, that's true for the large part. As I said, some studies now are showing in primary progressive there is some inflammation. So it could be that there are specific people somewhere. As I said, it's a very different disease in different people, even in primary progressive. There might be a set of people who might respond more than others. And the scan would help us with that. If you did a scan on somebody with primary progressive MS and they had active disease, meaning when you give them the scan, you give them the contrast, the dye, and it lights up, there are areas that are lighting up, that kind of person would tend to respond. If there was nothing lighting up, there was just shrinkage of brain tissue, they would be unlikely to respond.
This question is a vitamin D question. I take 2,000 units of vitamin D every day, but my vitamin D level is at about 35. Now, you said you like it to be 75, so what would you recommend I take each day?
Yeah, so, before people were measuring levels, they would say, oh, don't take so much vitamin D, it's toxic. But now we know we can measure the level. I have patients who take 10,000 units a day.
Okay.
Because that's the only way they get their level up. So if you're taking 2,000 and your level's 35, I double it, go up to 4,000.
Okay.
Maybe go up to 5,000 and check it again in a few months.
Okay.
But if you're 2,000 at 35, easy, go up to 4,000, get it up to 70.
Okay, thank you.
By the way, if you've asked a question already, you're allowed a second pass. All right? You don't have to pay to ask a question. Do we have any others back here? Oh, look, I get to do more running around. Oh, tripping over Karen's cart.
What are the indicators of that movement from relapsing remitting into secondary progressive? How do you decide when that has happened?
Yeah, so it's not a black and white clear definition. So what that means is the definition of secondary progressive MS, the strict definition is that someone has progressed and hasn't had a relapse. So if, for example, you have relapsing remitting MS and you have a relapse and your leg is weak and you come in 3 months later and your leg is still weak, that's a relapse. We know what made it weak. You had a defined relapse. There was inflammation in the brain. Your leg got weak and it didn't recover, or it recovered partially. So we know you're worse because you had a relapse. But secondary progressive MS is you come in 6 months or a year later and you've had no relapse, yet your walking is worse. Your walking has slowed down. Your memory is a little worse. So there is a slow progression without history of any relapse. That's the classic definition. But some people could have had a relapse that they didn't know about, for example, on a brain scan. So sometimes you might see someone that comes in and has no known relapse, no symptoms of a relapse, and you look at the scan and there's some active spots. And we're saying, you're still relapsing. So in the transition stage, we would still treat it as relapsing MS. In the early stage, we call that now a transition stage from relapsing remitting to secondary progressive. There's still a transition stage when a scan might show the activity, and we might still say, you might still respond to Solumetrol. We might still be able to put you on one of these medications because you're still having some relapses. Go ahead.
Oh. Hello, Dr. Steingo. How are you?
Oh, very good. So.
I got diagnosed with multiple sclerosis in 1996 at New York Columbia Presbyterian Hospital by Dr. Abitoff, Brian Abitoff. I want to know why I can't take gabapentin and stop the pain in my leg without having to take a narcotic. I'm against narcotics. Is there anything that's not narcotic that will stop these pins and needles? This pain is insane.
We have to put you in the symptom tower. But pain. There used to be a time, in fact, probably even 17, 18 years ago, when you saw Dr. Apatow, that they used to say MS doesn't cause pain. Some of you that have had MS for a long time might remember they said, oh, you have pain, you don't have MS. And of course, that's completely wrong. Most people, there's different kinds of pain that you can have with MS, but what you're referring to is nerve pain. And nerve pain is a pain that is burning or electrical. It's that kind of pain. And gabapentin works for a lot of people, but it doesn't work for everybody. That's why we have a lot of medications. If gabapentin was perfect, we wouldn't have anything else. Sometimes we have to use large doses. I'm sure you went up to large doses. If gabapentin doesn't work, we use Lyrica. So the medications that we use for pain are either the anti-seizure medications, such as gabapentin and Lyrica, and probably the best of all of them is Tegretol. Tegretol is probably the best seizure medication for pain, but it's older and it's got more side effects. That's why people use it less often, but it's probably the best medication for pain. For example, if people have trigeminal neuralgia, which some of you may have had, it's facial pain, which is a severe pain, I go straight to Tegretol because it's most effective. So we use anti-seizure medications as the first step. If they don't work, then the second step for pain is to use anti-depression medications. So we might use Elavil, those kind of things. You've tried those too. Cymbalta now is the new one in that group that we use. So those are two big groups that we use. Now, if those groups don't work for nerve pain, then typically we're going to start to have to use pain medications and use, and sometimes they even use pain stimulators now. Sometimes people go to pain management and they want to put a pain stimulator in their spinal cord if they have severe pain in their legs, for example. The problem with those is that sometimes you can't do MRI scans, but there are now new pain stimulators that are MRI compatible. So that's our steps. We try the anti-seizures, the anticonvulsants, and then finally you have to go to narcotics and pain medications.
And that's what my doctor down here put me on. Dr. Dwayne, my neurosurgeon, put me on clozapam. It worked pretty good for a while with the spasms.
That's for spasms, yeah.
I will only take 0.5 milligrams because the side effects that come with this are just insane. Liver damage, shallow breathing,
right.
And I'm not scared, but I'm a little bit
why you got
leery
to
on
watch
that.
every medication.
And just one other question.
Sure.
For the people who are, I'm not saying nobody's lucky who's got this disease, but the people who are more fortunate and are able to walk, there's no cure for me. But there's this new drug that I've heard of, and it's very big, and I think my brother said, I don't know, GB12. Will that ever come to America? I heard it's like a miracle.
Yeah, it's not a miracle. There is no miracle. I wish there was. You're probably referring to BG12.
BG12.
Yeah, that's approved already. That's Tecfidera, the drug called Tecfidera, which actually was approved last year.
Oh, it was?
So that's what Tecfidera is. Tecfidera is BG12. It's not a miracle. It works. It's an effective drug in the right people. I wish it were a miracle, but it is an effective medication. That's an oral medication. It's a pill that people take twice a day. It is available.
Okay, thank you.
Okay, anybody over here? One there, and then I'll be back to Laura.
I had a follow-up question about the secondary progressive. What I wanted to know, I noticed in your answer about it, discussing the treatment, and so what I want to know is if someone has secondary progressive, then does that often mean that the various drugs that we've been discussing do not work, and you treat people that have moved into secondary progressive in a different way?
So if you stick by what the FDA says these 10 drugs that were up on the board there are all approved for relapsing and remitting MS. And the FDA has only approved one drug for secondary progressive MS, only one. That's called Noventrone. That's chemotherapy. And it's toxic chemotherapy that very few neurologists want to use these days because it's so toxic. So if you have true secondary progressive MS, and I write that down in the note, and the insurance company says, what kind of MS do you have? And I say secondary progressive, all they're going to allow you to have is Noventrone. No others are approved. That's why we have to look carefully and say, do you still have a relapsing component? Are you in the transition stage? If you're way past it, if you're saying, I haven't had a relapse for 5 years and my scan hasn't been active for 5 years, and you're deep in secondary progressive MS, these medications are not approved for that. And those that have been studied haven't really worked. They have studied some of them. For example, Adherence was studied in secondary progressive, it wasn't effective. Copaxone was studied in primary progressive, it wasn't effective. So they've studied some of these. There's an ongoing trial now with Tysabri and secondary progressive. And some studies published in Europe have suggested maybe that works. But this is still in a trial stage. In a couple of years, hopefully we'll have information on that. But if it's strict secondary progressive with no relapses, these medications we wouldn't use. So we're trying to look for that relapse.
I have two questions. One is the temperature. You guys all say the same thing, that for the heat is no good. But there's a lot of us that the cold is the same way. It does the same thing.
Well, you want me to answer that one first? Yeah, so temperature. That said temperature, didn't say hot or cold, right? Because they do different things actually. So what heat does is that heat can make anybody here that doesn't have MS or that was in good health beforehand, you know that if you got into a hot tub or it's very hot out there, 97 degrees and humid, you feel a little weak. So heat slows down nerve conduction. So if your nerve conduction is slowed down anyway because you have MS and you get exposed to heat, then you can feel weaker. So what heat tends to do is make symptoms worse by slowing down nerve conduction. cold does something different. Cold usually doesn't make symptoms worse in most people. Now, it's a different disease in different people. You could tell me you feel worse in cold, it's possible. What cold does is that it makes muscles go into spasm. When people are cold, their muscles tighten up. Their joints are tight, their muscles are tight, they get more stiff. So that's the way the cold impacts people with MS often, is make their muscles tight and stiff. And then, of course, when it's cold and snowing, like it is everywhere except Florida, and there's water on the ground and it's wet, and you walk, and you have a balance problem, you have high risks. So the risks to the walking and the balance are much worse. So cold and things like that have their own set of problems, but it tends to be a little different. So they both have effects on people with MS. You're correct.
Okay, number 2. Do you personally do ANA testing?
I don't personally do it, but I do it in every patient. I send them for it, yes.
That's what I mean.
Yes, I know you mean that. So yes, at the beginning, not, at the beginning. So yes, MS is an autoimmune disease. It causes white spots on the brain. And lupus is an autoimmune disease that causes white spots on the brain. And sarcoidosis and Sjogren's disease and Lyme disease. And what am I saying? I'm saying that there are a bunch of diseases that mimic, there are many diseases that mimic MS. And they all can cause white spots on the brain. So when you are newly diagnosed, we want to be sure that you really have MS and you don't have an MS mimic like lupus or some disease like that. So at the beginning, we will be checking the ANA and the Lyme test and all the other tests to rule out all the diseases that mimic MS, absolutely. And it is common, by the way, for people with MS to have other autoimmune diseases, especially like thyroid disease or Crohn's disease, those diseases.
Wouldn't a spinal tap have shown that,
Shown that somebody could have lupus?
other than...
No. The spinal tap will show that someone has an autoimmune disease. And the more protein there is, the more suggestive it is of MS. But no, it won't show that they have lupus. It's just the blood tests.
Hi, doctor.
Hi.
You had demonstrated the arrow hitting the central nerve system.
Yeah.
Okay. If a person is clinically isolated, beginning stages of MS, why would you not go with the medication at that point where it happens so fast instead of waiting for more symptoms?
The answer is you would go for it at that point. You wouldn't wait.
Okay.
No, I'm saying at that point, you would go for it. You would start treatment.
Okay.
Many studies have been done on people with clinically isolated syndromes with most of the approved drugs that have shown the earlier you start treatment, the better it is. And yes, you would treat them at that point, right
so
there.
it was the first one that you wouldn't treat.
The radiologically isolated, right. When you've just seen signs of MS on a scan, but
Right.
someone's had no symptoms, you would say, now let's wait and see. And you would do a spinal cord scan as well. And if that's abnormal, then you would be even more vigilant. But that is where you would not treat. Yeah, but the clinically isolated syndrome, you would absolutely recommend starting treatment.
Okay, thank you very much.
Sure.
All right, we're just going to do 2 more questions, and we have them over here. You first.
Yes, please. Doctor, I'm trying to relate a corollary because of other health issues that I've had. There seems to be relationship between a compromised immune system that makes you more susceptible to having certain diseases be able to attack you. You spoke about the increased vitamin D. I've also, because of other issues, I was acidic and now I'm alkaline. I've changed that. When you're saying vitamin D, the medications versus vitamin D, are you trying to also build the immune system back? Are you trying to recapture it?
So we don't fully understand what vitamin D does, but what vitamin D seems to do is that in MS and other autoimmune diseases, there is what we call oxidative stress in the body. And I'm saying oxidative stress because everyone here has heard of antioxidants. And so the antioxidants are to counteract the oxidative stress. And for the cells to function properly, to counter oxidative stress, vitamin D is very important in allowing antioxidants into the cell. That's the way it seems to work. So vitamin D is not working on the immune system as such, not at that stage of it, not in the immune cells directly, but rather on the stress, on the damage that's being done to the cells to try and prevent the damage. That's where it seems to be effective. And it seems to be probably necessary for all autoimmune diseases, actually.
Hello. If medical marijuana is approved, would you approve it?
Yeah, if I don't go to jail by prescribing it, I'll approve it. Sure.
You think it's
I They just prefer to be free instead of going to jail. In this state, I'd go to jail. So, yes, it was approved. I mean, there are some places where it's approved, and there are some studies that show that medical marijuana helps some aspects of MS. For example, medical marijuana affects spasticity. So if someone had severe spasticity, I would be prepared to give them medical marijuana. However, if they don't have spasticity, I probably won't give it to them. It's been well shown that medical marijuana helps spasticity, but it's also been well shown that regularly taking marijuana affects cognitive functions. So people might be very happy, but they're also dumb. So pick what you're going to. Yeah, they're happy. I'm happy. I don't know why. So the answer is, if it's an approved product, I have no reason not to give it. You can get a nasal spray. There's an approved nasal spray of marijuana in Canada called Sativex. It's a nasal spray. You can actually go and get it, and we could use that. So if it was approved for medical purposes, in the right person, we would use it.
Okay, sorry, but one last question.
Hi. Is there an advantage to taking vitamin D3, which is already synthesized, rather than
Yes,
vitamin
that is
D?
the form we recommend. Vitamin D3 is the recommended form of vitamin D. You had a question? Yes, Stu. One more question.
Question somebody has is, living in Florida, doesn't that allow for all that vitamin D coming in?
Yeah, I mean, you get more than you get in Minnesota, but it's still, people are still deficient. Every day people are deficient. Yeah, it's not enough. Yeah, we still have to take some. Fortunately, it's easy to supplement.
See, I didn't get around to this side of the room, and now there's a question here, too.
Okay.
You said that genetics played it. My brother was diagnosed with ankylosing spondylolisthesis, and I have MS. And when I went for my second opinion when I got diagnosed, he said that was like very rare. But do they see that more commonly now?
No, I would say in people with MS in general, they are in their families, in themselves too, and in their families there are more autoimmune diseases. That's not a particularly common one that you just mentioned, but it's the common diseases that are seen in family members are thyroid diseases like Graves' disease and Crohn's disease. That's the two commonest ones, but there's others too like lupus, and probably this one too could happen. It's just not a common disease.
Okay.
Great. So with that, we want to say thank you to Dr. Steingo. And we're going to ask Mary Robinson to come on up. And she will take the mic, and we'll just get started right away because she wants to make all of you happy people.
I want to tell you, first of all, that I'm glad to be here, and I'm glad you all are happy, or I hope you will be. So, happiness, and we'll spend a little time looking at happiness in a few minutes. But I'd like to begin with inviting you to be present now. And if you wouldn't mind putting down your forks just for a moment.
Wow, this is making me happy.
And I certainly will invite you to come back and use your fork again in a moment. One of the ways of being in the now is to relax and settle in. You've been listening, you've taken in a lot of information. And so at this point, would you just make yourselves comfortable in your chair for a moment? And you don't even have to look at the screen or at me if you feel comfortable, just closing your eyes and focusing on your breath. The breath is the fastest way to get to the now, to the present moment. I know Stu says he doesn't know very much about now and the present moment, that he's very interested in what's going on in the future and how to arrange things for the future, and certainly that's what we've been hearing a lot about how you can make plans for your future. But the now is where we have to start. So I would invite you right now to allow yourself just to be comfortable, and if you would be comfortable closing your eyes or looking down, and then just becoming aware of your breath, which is something that's always with you. So just for a moment, paying attention to your breathing as you're breathing in and you're breathing out. You're sitting. We have nowhere to go for the next few moments. We have nothing to do, just being present. And if perhaps you are aware of the silence that comes into the room as you sit. and you breathe. And I invite you to be here now in this moment. Breathing in, breathing out. Perhaps saying to yourself, breathing in, I know I'm breathing in. And breathing out, I know I'm breathing out. Pushing nothing away, just being open to the moment and the breath and this moment. Feeling your body supported by the chair in which you're sitting, your feet on the floor, present in the now. So the bell that you heard is also an invitation to come back to the now in this room. Forks, dessert, coffee. Open your eyes, find your mouths and your taste buds, and begin to be aware of happiness. So why is it that we want to be happy? Have you thought about that? And are you happy right now on a scale of 1 to 10? Just take a brief encounter with yourself. Where are you on that scale? And I'm also reminded of that childhood song, if you're happy and you know it, clap your hands. If you're happy and you know it, clap your hands. So clap your hands. Let's get some energy going here to be happy. So why would you want to be happy? Well, we feel good when we're happy. We get along with people a lot better when we're happy. And not only that, we're less anxious and we're less fearful when we're happy. So exploring how to be in touch with that happiness becomes a really, really helpful thing, particularly for those of us who have chronic disease. Research at the University of Kentucky tells us that positive emotions created a 10-year increase in the lifespan of the people that they studied. So that's also a recommendation for happiness.
I'm 92.
So what is this? What is this happiness that we're talking about? What is happiness? Is it genetic? Some studies say, well, we got about 50% of our emotional makeup, our attitude, from our genes, and only 10% comes from circumstances around us. Well, what about that other 40%? That is what we have under our control, and that's what we want to look at in terms of looking for happiness. So here's somebody's idea about a formula for happiness, and I'm sure you've probably heard about butterflies and happiness in your lifetime. In this quote, happiness is a butterfly, which when pursued is always beyond our grasp, but which if you will sit down quietly, as you just did, might alight upon you. Positive psychology is one of those aspects of life that studies happiness, and there's a wonderful center for positive psychology at the University of Pennsylvania. And at this center, they have an educational program to help people, children, young people, adults, develop positive emotions. And so they say that the things that make up positive psychology and that help positive emotions are happiness, pleasure, and well-being. So positive psychology, what does it have to offer us? It also asks the question, what makes life worth living beyond just being happy in this moment with that wonderful chocolate dessert? Happiness is something that can be learned, and it's something that students found when they did a research project. They were invited in their research project to plan something that was going to give themselves pleasure and evaluate their response. And then the next thing that they were asked to do was, when they completed that part of the project, to move on to finding something that made others happy and pleasure, gave others pleasure. And they found, these students in their reports back, that both giving pleasure to themselves and giving pleasure to others was very, very rewarding So the quote was that doing good is a good thing. Here's another way of looking at happiness, that real happiness depends on what we do with our attention to connect to ourselves and to our own true experience and the ways that we connect with other people. So what is it that we do with our attention? What do we have to learn about giving our attention that can help us to be happy? Well, who better to teach us than Charlie Brown, of course, who said that pleasure, giving our attention to pleasure, is one of those wonderful things that creates happiness. And you know how he did that with his warm blankie and his little Snoopy dog. And I heard just the other day that your happiness level increases if you have on warm, fuzzy socks. So if you haven't tried that, you might try that one next as a way to have pleasure and feel that pleasure. Then the other aspect of happiness is this aspect of doing good, doing something that offers pleasure to other people. And this is a quote from Martin Seligman, who's really the father of the study of positive psychology. He says, lasting happiness comes from doing things that makes life worth living. That kind of altruism, that altruism really feeds happiness. So if these are all the things that we can look at with happiness, can we really choose to be happy? Can we choose to focus our attention on things that allow us to be happy? And if we look at happy people, what is it that we see? We start to pay attention to people around us who are happy. They're good role models. What are they like? They focus on the present moment, not on the past or the future. And they simply see things arising as they are in the moment. And then they're more in a state of being constantly happy because they can accept that life is constantly changing. You know, we create a lot of our own unhappiness and stress because we try to hold on to things. We try to hold on to those things that feel good. And we try to push away those things that don't feel so good. And that causes us a lot of stress and unhappiness because life is always changing. So even the happy things that we have are for the moment to be enjoyed and to have that kind of pleasure. So here is another way of looking at happiness, and this comes from the work of Dr. Ron Siegel at Harvard University. And the science of a meaningful life is the way he couches his work. And he says these are some of the pathways to enduring happiness. We learn to identify and use our strengths. We pursue gratitude, savoring flow, and have a meaningful life. Well, what does that all mean? Well, how do we identify our strengths? There is a survey that you can take if you're interested, and I have a handout that I'm going to give you after I finish speaking tonight, and it includes a link so that if you'd like to find out what your strengths are, you can go online, take the survey, and find out what are the strengths that you have. But you can imagine that in addition to the ones that are listed here, creativity, curiosity, open-mindedness, etc., that there are some that are more likely to generate happiness than others. Gratitude, love, compassion, kindness, those are the ones that rank really high. If those are your strengths, then that's a real help for you being happy. So once you've identified your strengths, then Dr. Siegel says that we need to use those strengths once a week or more. Every day for a week you might choose, today is the day I'm going to be more compassionate, I'm going to be more grateful, I'm going to be whatever. I'm going to experiment with what that's like and see what that does. Because just as we know muscles that we use become stronger, so that qualities that we use in our lives also become stronger. So when we choose to focus on a strength, it's a little like thinking of watering and nurturing seeds in your garden. How many of you all have gardens and you know what that's like? So knowing what the seeds are, you might have a garden like the one on the left, or you might have one on the right. Which one would you prefer? The one on the left looks a little bit like my granddaughter and my attempt to grow pumpkins. We did not water and nurture our pumpkin seeds very well, so they began to not look really, really, really healthy. I'd much rather have the one on the right, and perhaps you would too. So mindfulness is one of the ways that we know that we can water and nurture the garden, which is really our life, the qualities of our lives. So to remember that we can improve our health and be more compassionate towards people, as well as growing more happiness by paying attention to certain qualities in our lives and watering them like seeds in our garden. These are the things that make life worth living, and they become the pathway to happiness. A pathway that might look like this, or perhaps you have one in your mind. What does your pathway to happiness look like? Is it something that's a trail in the mountains? Is it a ski slope? Is it a stream? Is it the beach, like this scene here? So another one of the qualities that makes life worth living and that is important along our path is cultivating gratitude. This appreciating what you do have and not dwelling so much on what you don't have. Gratitude, cultivating that sense of appreciation when people do things that are nice for you. Being able to say thank you, being able to say please, connected with people. It gives you a sense of belonging as you do develop your sense of gratitude. And then the sense of savoring. That's kind of an interesting word, isn't it? It's what you did with the chocolate cake. But savoring has some other qualities too when you apply it to being here in the moment. So I'd like for you right now to be here in the moment. That's the first thing that we have on the list. So just check in. And one of the ways that we have of being in the moment is that we can use our senses. So check in with that sense of taste. You just had something yummy to eat, or maybe you didn't eat the dessert, but you had a lovely dinner. What's the taste that you have in your mouth? It's one of the 5 senses that helps us know we're in the now. Your sense of hearing, you're listening to me. There are other sounds in the room that you may hear, but that lets you know that you are here now. Your sense of seeing, if you have your eyes open, you're looking around. Your sense of sight lets you know you are here now. You are being in the moment. Your sense of touch. Have you noticed the temperature in the room? I found it a little cool myself. But our sense of touch, our skin tells us we are here in the moment. It tells us about the clothing that we have on and the chairs in which we're sitting. So all of these senses that we have help us to be in the now. And by paying attention to our senses, we can begin to change and train our minds to focus on the present moment. And this develops something called psychological fitness, which allows us to deal with life in a very different and more balanced way. And here's another view of savoring. For those of you who are pet lovers, you might want to contemplate what it is like to watch and have something else watch also. To watch and be watched. And who is looking at whom here? Another aspect of our ability to cultivate happiness is being in the flow. And I think we hear a lot of that as it relates to athletes. We've probably heard a lot about that as we've seen what's been going on with the Olympics. This giving attention to being completely absorbed in the moment. We may lose track of time, or we may be completely engaged in the here and now. Believe it or not, I think when people are engaged in the here and now, even if it is shoveling snow, they might find that that was a happy thing, or we can be happy just looking at that and saying, oh, I'm so glad that's not me. And here our athlete is an athlete. I'm sure you've seen lots of those pictures as you've seen the Olympics in this last couple of weeks. The person who's totally lost in their activity. They're in the flow of life. And this is a seed of happiness. What an important way to understand happiness. So what is happiness leading to? It leads to a meaningful life, really. Being a part of something outside of yourself that gives you purpose is another one of those important aspects. So that cultivating happiness and positive attitude, it's an inside job, but you might do it with other people. here's a group of people who did something together that they probably couldn't have accomplished alone, but they did it and they look very happy and pleased with their results. So the next aspect that I'd like to share with you is the possibility that you might develop some happiness habits. So what would be one of your happiness habits?
Taking care of yourself first.
Taking care of yourself first, and knowing how to do that. Sometimes we have to figure out a way to do that by just sitting still for a few moments and contemplating, well, how would I take care of myself? What is it that I need? I need to be quiet. I need to be watchful, as this person has chosen to be in this picture. We can improve our concentration also. And when we do that, we can be with what is, the way that it is. We can pay attention to ourselves and the conditions around us without being constantly judging, commenting, running a commentary, comparing, winding up with some kind of negative evaluation of what's going on right now. So by improving our concentration and just staying in the now with things the way that they are becomes a very important thing. There was a lovely quote from an MS patient in one of your recent magazines, and she says, "I've been practicing mindfulness meditation, and it helps me remember that I didn't give myself this disease. This is simply the way that it is. A certain level of acceptance. Now is the way that it is." And that unconditional acceptance, which is not easy for us to arrive at. Another happiness habit is the possibility that you could recognize your thoughts as just thoughts. They are events. They are not facts. Sometimes we forget that. We live so much inside our heads that we decide that perhaps what I'm thinking is how it really is until we have a chance to check that out. But we can create some catastrophes in our minds. They are not facts. They are ideas. And a man named Dr. David Moore has created a stress and mood management book for individuals with multiple sclerosis. And he says this helps identify negative thoughts, ways to challenge them. And it also gives persons an opportunity to look at relationships and activities that help to promote happiness and positiveness in life. That will also be on the resource sheet that I'm going to give you at the end of my talk. And remember that wonderful Robin Williams movie where he was the teacher in the private school and he went around and his great message to the students there was, "Carpe diem, seize the moment." So this is another one of those very important qualities about cultivating happiness and being positive. And sometimes that's just being aware of just ordinary moments. As a grandmother, I feel very blessed to have a lot of ordinary moments with my grandchildren. They were recently on the dock catching fish in the canal and having a wonderful time, and they had 6 fish, and it didn't bother them at all that they were catfish and they had to throw them all back because they are not keepers. They thoroughly enjoyed just doing what they were doing, and I was getting a really big thrill out of just watching them be together. So another aspect of being in the moment and seizing the moment is that we can relate to change better. Remember, since change is inevitable, trying to hold on to it is something that's not under our control. And when we recognize that, perhaps we can find ourselves less stressful and more happy. And then to free yourself from some negative feelings. This is a picture that I used in a class that I was teaching in mindful eating, and the caption that went with this picture was, "What did you bring to the table with you?" Because sometimes we bring our negative feelings even to the food that we eat, as well as to our everyday life. So to know and identify what your feelings are, your fears, your angers, your upsets, your pain, without giving in to them and having them just control your thoughts, your behavior, and your moods for the whole day. Because feelings do create moods, and as we become aware of our our feelings and can name them and take control of them, we're in a much better place to choose to have a happy life. Remember, that's what we were looking at to start with. Can we choose happiness? And then finally, the inner critic that lives inside my head. I'm assuming you probably have your own. The one who criticizes and comments, and if someone says our brains are like Velcro for negative experiences, chances are we remember those experiences a lot more than we remember positive experiences. So knowing that you have an inner critic, but you're not alone, everybody else has one too, they just don't happen to have yours. So in dealing with your inner critic, you can stop ruminating about the past. It's done, it's over with. To quiet your fears about the future, because the inner critic can certainly stir you up there too. And this is about training your emotions so that your feelings and your thoughts and your emotions are not always impacted by the constant voice and the constant chatter of the critic who has a comment for everything, if you really want to listen. So to complete what I need to say to you, I saw this lovely photograph of the child chasing the bubbles, and I thought, you know, the more happiness and joy there is in the world, the better it is for everyone. And then a little bit closer to home, maybe some of the rest of you saw the same story in the news press that I did last week. A young man, 14 years old, Joseph Rosa is his name, and he's had brain cancer for 5 years. This is what Joseph says. You need a reason to be sad, but you don't need a reason to be happy. So I'll leave you with that thought, and I'll also leave you with some papers that you can follow up yourself, tips for being happy and what happiness is.
Thank you, Mary.
You're going to make somebody happy with a raffle?
Yes.